Good morning. Did anyone else have trouble waking up this morning? Yeah, everyone? Oh, good. 2 hands for me. I know. Oh, you couldn't raise your hand. For those of you who do not know, this is Beth Gore, and Beth Gore is Oley, president of the board of directors. So watch out. Got to be on our best behavior. She's in the front row. So we have a very exciting program this morning for you, but in a more relaxed setting. After a day and a half of 20-minute lectures, breakout sessions, lunch, you got to be here, you got to be there. This morning we thought we'd just sit back and we set the stage for it. So don't get too comfortable, speakers, but anyway. I think before we begin, we want, as Oley staff, we want to say thank you all for joining us, and there's more trickling in, I'm sure, but especially the 3 speakers on a Monday morning. We're really, really grateful to have everyone here. We'll start the morning. What better way to start the morning than with diarrhea? Isn't that great? I mean, really, this is Oley. I believe Dr. Darlene Kelly needs no introduction. She is formerly managed one of the largest HPN programs at the Mayo Clinic in Rochester, Minnesota. She retired for about 5 hours, and Oley brought her on as... Well, this is my story. I'm at the mic. It's my story. Come on up. Come on. That's a different story. That's the second chapter. Here you go.
Thank you. I would not like to make a major.
There you go. There you go. Good. Okay, speakers, you're on camera. Please speak so viewers at home can hear you. Welcome the virtual audience also.
So
Dr.
I'm
Kelly.
on? Okay.
Yeah.
Well, good morning. I think it's relevant that we have the most comfortable chairs that have been in front of this room over the entire meeting. So, Russ, we're kind of in trouble here. If we all fall asleep, we're in bad shape. But anyway, we'll try not to. Well, once I was introduced by one of my friends, Marion Winkler, who said I was an expert in diarrhea. And I wasn't quite sure how to take that, but it was in front of a crowd of about 175 people. At any rate, that's my topic today. So anyway, this was the first day that Joan called me and told me I was late to work was when I had just left Mayo, and it was the first day I was supposed to be at Oley. All right. I don't really have anything to announce as a conflict of interest anymore because of being retired for 6.5 years. So at the end of the session, you should be able to list the potential causes of diarrhea in a typical consumer of home parenteral and enteral nutrition. I'm getting a lot of feedback here. Is that okay? To describe the science of these diarrheal illnesses, to identify ways to avoid diarrhea. In many ways, it's altering your diet. Sorry about that. And also to discuss potential treatments for diarrhea. So instead of drawing it all out, I just gave you a list of the normal gastrointestinal tract, which is anything from the mouth to the anus. And you will notice all the centimeters of the various parts of the small intestine, especially, and also of the colon. And to remind you how to convert this to inches, 2.54 centimeters equals 1 inch. So if you divide these numbers by about 4/10, about 0.4, you'll learn what the length is in inches. Well, how large is the small intestine? And just looking at these numbers, how many think it's bigger than an elephant? Nobody thinks it's bigger? Oh, well, okay. In the first two rows, I see some of our experts, so they've heard this one before. How many think it is bigger than a bread box? Okay. And how many think it's as big as a doubles tennis court? And all that I can say to that is, wow. It is a lot of space, and it's more than you really need. And you can lose some of that small intestine and still do okay, but there are times that it isn't okay. So let's look first at how in the world it got so big. It's an ever-increasing surface area. So if I took a piece of small intestine and cut through it, you can see, okay, I don't know how to point to both of these, but anyway, you can see the pink part are the small intestinal folds. And the green part is supposed to be just stuff going through. So if we take that and look at those folds, you can see that the folds are quite large, and they increase the surface area by threefold. Does this, oh, it does work, okay. Then if we take a section here and look at it after we've cut down, these are the villi. They're tall, finger-like areas. They're tall compared to other things, let's say. They're not so tall, they're not this tall, for example, or maybe that tall, not much bigger. But they increase the size by 30-fold more, so we're up to 90-fold increase at that point. And then if we take just the tip of a villus, that's the singular for villi, and you can see that these are what they sometimes call a fuzzy covering. And these are almost little hair-like things that stick into it. It increases at another 600 times. So altogether, it's 2 million square centimeters in the small bowel, which is pretty impressive. And I think these slides may be in the website when you finish, so at any rate, so one of the most important things, if you are communicating with your doctor or whoever, the team for home parenteral nutrition and even home enteral too, is to know what's been removed. For example, the duodenum and the jejunum versus the ileum. You're really better off if it's duodenum and jejunum that's resected compared to the ileum, because the ileum has specialized function. In particular, only the ileum is able to absorb bile salts, which help you digest fats, and vitamin B12. These are both active functions of the ileum. So that's why I say that proximal, the first part of the small intestine, is easier to replace than the ileum. And I will say also that most of you who've had small bowel resections, it tends to be the ileum that's been resected. How much remains? Well, it's best to have, okay, most of this audience is too young to remember this, but some of us aren't. A meter stick. Did you have a meter stick in your school? Some of you are looking like, huh? What's that? Well, anyway, it's a bit longer than a yard. It's 39.37 inches. So, and they tend to express these things in the metric system. So, and what else can affect how well you do with the anatomy is the stomach still intact. It controls the emptying of the stomach, and it will also get some feedback from distal areas that slows down emptying. The colon is helpful with absorption as well, which to a lot of people think that's pretty crazy, but the colon will pick up water. You will have some digestion going on in the colon. And that tends to be a part that is often missing in people with short bowel. Medicare's definition of short bowel, and I don't know how they came up with this, but it's anything less than 5 feet remaining. I'm sure not very many of you who have short bowel have 5 feet remaining, but there could be a few, and we'll talk about that in a second. Practically, if you have 100 centimeters of healthy small bowel, even with no colon in place, you're often able to do okay off TPN, and you may require the TPN, which is total parenteral nutrition, versus HPN, home parenteral nutrition. At any rate, you may be able to do well eventually. Sometimes it takes a while before you can. I had a patient once with 60 centimeters of small bowel and did not have colon in place, and he managed, but it was an insurance issue, and he just couldn't afford parenteral nutrition. But at any rate, if you have anything more than 60 centimeters of small bowel plus colon, you will do pretty well, often get off of TPN. And if you have active disease in any of that section that's remaining, you can require TPN even if you have a huge amount, even up to the 5 feet of small bowel in continuity. Now, there's a concept of intestinal adaptation. And what happens is the intestine can actually increase in length a bit, especially in the peds kids. The diameter gets bigger and the villi get taller, so they're a bit more efficient at absorbing. If you increase, when the adaptation starts is actually while you're in the recovery room, but it takes a while for it to get up to speed, which is about 3 months, and it can continue for up to 2 years. So if you have someone who's had a resection, you can kind of help them understand that over time they might be better off than they are right now, right today. Frequently, after adaptation has totally occurred, you may be able to wean or at least decrease your TPN requirements. And I keep saying TPN, and I know you probably think HPN, as does Oley, and I apologize for that. So this is the story of intestinal adaptation. Okay, so if you have nothing by mouth, the villi get stumpy and don't absorb very well. And this is even true if you're on TPN or HPN. By contrast, over the next 1 to 2 years after some of the intestine has been removed, you may develop supervilli, so they absorb really well. And that's why the way it is at day 1 post-op versus 2 years from now may change markedly, and especially if you follow what I'm about to tell you. How many of you remember hearing about osmosis in grade school? Now, some of the younger ones of you probably learned about this in about 4th grade. I probably learned about it in maybe 7th grade. And some who are older may never have learned about it. But anyway, osmosis is something that helps us out a lot, or not. This is a glass tube, and there are 2 parts to it, which are joined here with what they call a semi-permeable membrane. And that means, well, I'll go to the next slide and you'll see, these are molecules that are coming in. And on one side, we have sort of a small amount of molecules, and on the other side, a lot. Now, these molecules are bigger than the holes, so they can't go through the holes. So only water can move. Another test question is, will water go from the left to the right or the right to the left? How many think they're going to go from the left to the right? The water moves, okay? Okay, we've got a few. And how many think from the right to the left. Okay. And in fact, it is going from the right to the left. And we're going to rename these sections. On the left side are the contents of the small bowel. On the right side, the blood. And this semi-permeable membrane is the intestinal wall. And we're going to call these molecules sugar at this point. Are you starting to get a little message here? And we call the left side diarrhea, and we call the right side dehydration. Does that make any sense to you at all? Okay. So sugar is a problem for you, especially excessive amounts of sugar. If we measure the osmolality of the blood, the number is 300. You don't need to know the details of that. But we want to keep the fluids that you take in below the number 300. And that will favor absorption. I'll explain this a little further. So I'm down to the so what. Fluids that side, probably 235 to 350 are best to preserve the amount of fluid in the intestine. To preserve the amount of fluid in the body. And if it's outside of this, it can cause diarrhea. So let's look at how much the osmolality is of a number of beverages. And I'm going to start kind of at the bottom here with carbonated beverages, about 700. These are ones with sugar in them. And the point is that that good old Coke will cause you to lose fluid. Okay? Kool-Aid with a cup of sugar is less concentrated than the carbonated beverages. Orange juice at 614 is about twice as concentrated, in fact, a little more than twice as concentrated as should be helpful. And how many of you, even if you like the taste of it, would drink prune juice? Okay. Oh. But you're cheating, Ann. She's just trying to knock me off my post here. So where sodium goes, water follows. And this is called co-transport of water and sodium. And so we have here glucose, which is pulling its carrier with salt blocks in it. And this guy's supposed to look like he's moving. Well, he doesn't. But anyway, this is water. And where sodium goes, water follows. So it does take some sodium. It takes some salt in these to actually turn on this co-transport function. And it takes some sugar as well. Oh, now he's running. Okay. World Health Organization had originally not a reduced osmolarity product. They had one that was even higher in salt. But then they began to realize that even people with cholera, if they had a very high osmolality fluid in their intestines, would actually lose fluid. So then they cut back on the amount of salt, sodium chloride. Another thing they did, sodium bicarbonate really doesn't taste very good in this, and they replaced this with tricitrate sodium, which is tasteless and odorless. But it does, as I said before, it takes some table sugar and it takes some salt to get this to work, okay? And the idea of this is it's a sipping solution. You don't chug a lug 6 ounces or 8 ounces of it. You try to just sip it while you're sitting in one of these nice chairs through the day, reading or whatever. Now let's look at the flip side of this. What about water? Well, osmolality is close to 0 in water, just plain water. And the intestine gosh, it seems like the intestine should absorb it like a sponge. Well, that doesn't happen. What happens is, in short bowel especially, with no colon, water is a very poor hydrator. I once saw a woman who was probably going to be in the Olympics. She was an athlete. And her doctor, she ended up with short bowel right before the Olympics. And her doctor said, well, you're not drinking enough water. So she drank more water. And what happened is her diarrhea got worse. Then they put her on a product that some of the clinicians here will remember. It's a lot of sugar and a lot of sodium, but the amino acids are not intact. They're not like a protein. They're free amino acids. And this was supposed to be a wonderful thing for absorbing, but in fact, it caused even worse diarrhea. And why? Because there's no sodium in water, there's high sodium in the blood, and we're not including sugar here, so we aren't worried about the co-transport, but sodium will move into the intestine, moves downhill, and it takes water with it. So that will actually increase your diarrhea. So don't drink water, at least not free water. Now, what about sugar substitutes? Are they always okay? Well, this was an interesting story a number of years ago when people were using this sugar-free gum, which had sorbitol in it. And sorbitol is an unabsorbable alcohol that we cannot absorb. And so what happened, especially if they were having stick after stick after stick, is they had what's called chewing gum diarrhea. So some of the artificial sweeteners, and these are added, by the way, to a number of medications, especially for kids that you're trying to get some liquids down or something. If the colon is intact, what happens then? Well, if there's a small amount of ileum that's been reserved, and some bile is malabsorbed but replaced by the liver, and in the colon, bacterial action on the bile causes water secretion. So you treat that by binding the bile. The contrast is when a large amount of ileum is removed, the bile is depleted, the liver can't keep up with what you're losing, so the bile acid pool causes, the decrease in it, causes very poor fat malabsorption. When that fat goes into the colon, the bacteria there will act on it, and it'll make something just like castor oil. Now, the younger of you probably have never heard of castor oil. The older of us have probably had it at one time or another, especially when prepping for x-rays. At that time, scopes weren't quite as popular. And so I usually will tell you it's like a go lightly in your age group. Now, we'll do a flip-flop here to intestinal dysmotility, and I have just a couple slides for that. It's sometimes called the bacterial overgrowth syndrome, and it does cause diarrhea, but for a different reason. When there's normal motility, you can think of a beautiful big river that has the water flowing normally, and the contents of the intestine are somewhat clear. That's normal motility. But when the intestinal contents move very slowly through the gut, the bacteria increase in numbers. There are lots and lots and lots of bacteria in the colon. And I read it the second, I can't remember the numbers, but they're really high. And have you ever been in a river that has backwaters where the water is not flowing? If you go over to the Mississippi and you see some calm waters, but you look down and they are not clear, they are really buggy. And so that causes diarrhea. Now, some of the drugs, antidiarrheals, will slow some intestinal motility to try to help the diarrhea. And loperamide is one of the ones that we often used, and some patients would say it doesn't work. Well, there are some hints to make it better. For instance, if you use that medication 15 to 30 minutes before you eat and at bedtime, you will have a better benefit than if you take it after you eat or when you're not eating at all. If you crush it, it improves absorption. And probably if you are going to try loperamide, the first day don't take 15 of them, okay? Because then you will have quite the opposite problem. You'll be absorbing really well, and you will have very solid stools that don't go anywhere. So what I usually do is start out slowly, maybe 1 pill before 2 meals a day, with or without one at bedtime. And then we can see how well it works. And if you have a lot of diarrhea, it may take significantly more, and it might take more than the drug company says you should use because you're not absorbing that drug, okay? Some of the other narcotic medications, or some narcotic medications do help here, but there are so many side effects that if you can find something short of narcotics, it's a good idea. For instance, addiction, mental blunting, tolerance, where you need more and more and more as time goes on to control the diarrhea, and interactions with some of the other medications that you're using. So in summary, some of the things I'm going to suggest for short bowel diarrhea: try to limit your sweets, try to limit the high osmolality drinks, avoid free sugar, coffee, tea, diet pop, because all of these things are just like the free water. Limit fats, especially in people who have colon present, or for the people with motility disorders, try to treat the bacterial overgrowth syndrome. But remember, it all depends on your anatomy and on your GI function, so do keep that in mind. So that's my story.
Okay, our next presentation, expanding options for the treatment of intestinal failure and short bowel syndrome. I heard Dr. Merritt speak, when was it, at the regional in Santa Monica, May 11th, but I don't really remember too much now. I liked the idea, the format of his presentation, really relaxed, which is what we want this morning to be more of. And it's 10 questions worth asking. And I thought, how appropriate for this audience. And while he makes his way up here, we're concluding this morning's session, when we're ready to conclude it, with an in loving memory celebration salute. And then we will meet right outside here at registration and make a decision as to whether we walk. Do we walk in the sun? Do we walk in the rain? Do we risk a storm? And then we will make our way to a pavilion. There's a covered walkway to get there. So regardless, we'll be safe and happy.
Do they walk around Lake Superior, Joan? Or, sorry, are they going to, Joan?
Thank you. Pardon me.
Are they going to walk around Lake Michigan?
Walk around Lake Michigan. That's a great idea.
Well, good morning. It's always a pleasure to participate in an Oley meeting, and I thank Beth and I thank Joan for the opportunity to be with you here today. I work with an intestinal rehabilitation team in Los Angeles, and we're very family-oriented. At least we try to be, in the way we approach intestinal failure. And I want to share with you today what I think are 10 questions we can, just as I'm going through this, these are my disclosures. I've been in industry for a while and I do some consulting work. but I want to look at 10 questions that we can ask together about your care and see if doing this little bit of a checklist maybe adds anything to summarizing what you take home from the Oley meeting. So the first of our 10 questions today is, do I or my child, depending on the situation, have access to expert care? And increasingly, I think the care of intestinal failure is being concentrated in centers of excellence. There are reasons for that. I work with NASPGHAN, the Pediatric GI Association, and in late 1917, we published a paper looking at the importance of intestinal rehabilitation teams in the management of intestinal failure. And the conclusion of this group was that the reliance on such teams really is the standard, the current standard of the art, and it's important that in patients with short bowel syndrome or other forms of intestinal failure who are not making progress towards being free of TPN, that they have access to this kind of care, particularly if there are any of the complications of TPN and short bowel emerging. Now, it's legitimate to say, well, are the teams promoting this because they run the teams, or are the teams promoting this because there's evidence that this really makes a difference? And on this slide, I've summarized some of the aspects of care that seem to be improved by these teams, particularly in centers who have collected data before the team and then published data after they have a team. So there's some evidence that survival is increased, and there's a lot of evidence about what these teams do differently. They work harder at getting patients off of TPN. There's less progression of liver disease. There's more use of modified lipids. They're more likely to do intestinal lengthening procedures. Dr. Powers just talked about bacterial overgrowth, and these teams are more likely to treat that. And if patients need transplant, they're more likely to be transplanted. There are also newer ways of getting to intestinal rehab centers. In my state, for example, there's now mandated transportation in patients with chronic disease. And if you work with your team and your social worker, it's often possible to get transportation if that's a limiting factor for you, as it is for many of our patients. Different centers are making different levels of progress with telemedicine. And most recently, there's a new concept called the LIFT program. In the case of TPN or home TPN, it's called LIFT Echo, run by Dr. Kishore Iyer out of New York. And this is a way, if you're in a rural community and dependent on a doctor who's not part of a team, your doctor can now hook in a couple of times a month with world experts and listen to them discuss cases, ask questions of these experts, and in time become an educated expert himself. So this has been used in a lot of other disease states and is now being used to expand the availability of quality care for TPN. The next question is a very basic one, but it's, have I had an infection, a central line infection in the last year or last 3 years? Because we tend to think that if we're trying to keep the infection rate down under about 1 per 1,000 days. So that's roughly 3 years. So I think it's a relevant question if you haven't gone 3 years without an infection. If you have had an infection, then are you doing what you can to prevent it? And one of the newer techniques, and I'm sure many of you utilize it and are aware of it, are ethanol locks to kill the bacteria, remove some of the residual material that builds up in catheters. And in patients who previously have had very high rates of rehospitalization for infection, sometimes the rate of hospitalization has been decreased as much as tenfold with the intervention of these kinds of locks. There are some potential issues with the use of locks, but generally the benefit outweighs the risk. Some people have used antibiotic locks instead of heparin locks, and there's a product in Europe available called Toral lock that seems to have a lot of desirable characteristics but is not available in the US. Otherwise, you need to be in a hospital that uses bundle policies if you go in for a new central line. And I think most hospitals in the US do this now. But these policies regarding asepsis, or keeping bacteria away from catheters, have really had a dramatic effect on reducing these infections in the hospital. And we try to use then some of these same techniques for home TPN patients. Biopatch at the site can reduce infection. And from my observation, I think paranoia is very effective. So if you have a little of that, that's a healthy thing in this instance. We have patients who do care a little differently than what we recommend, but it's usually on the extreme end. And I don't see those patients coming in with infections. So, okay, the next question is more a pediatric one, but may be relevant in other ways. That's, how can I protect my child's catheter? From my perspective, catheters are an attractive nuisance, just like a swimming pool for a child who can't swim. And so we need to try to keep the catheter out of the hands and mouths of children. So we tape them securely. There's a special way of doing that. We use the ethanol caps at the end of the catheter. We use a lot of vests to keep the catheter in a different place from right here where a child can play with it. And I think it's very important not to have the catheter tip anywhere near the diaper or an ostomy. And it's based on some experience. So we routinely have our nurses try and put the catheter somewhere else. This is an example of vests that we're using in our center made by one of the mothers of one of our patients. The next question is a central one, and that's, how do I avoid running out of veins? And what leads to losing veins? Well, it's infection. It's getting a clot in the vein or in the catheter. Having multiple catheters placed in multiple sites, particularly using a cut-down technique that some surgeons need to use. And this can be assessed, your catheter status can be assessed by ultrasound, contrast studies, MR studies, and it's important to do that periodically over the course of maintaining central venous access. Now, recently, there's a forthcoming publication in the journal Parenteral and Enteral Nutrition, and Beth can talk to this because she's actually a co-author on this paper, perhaps better than I can. But I think that the key message here for me, and I think it's kind of revolutionary from a patient perspective, is we medically have treated catheter placement as an incidental series of episodic events. Oh, you need a catheter? Okay, we'll find a surgeon, we'll put in a catheter. And moving forward, what this Vanguard group is recommending is having a prospective venous access plan for a patient so that catheter replacement is not an ad hoc event, but you know what you're going to do and what your plan is for the future and where you are in the course of running out of veins. So I think this kind of thinking will have a lot of impact, and again, I think it's the kind of thinking that's more likely to go on in the centers of excellence. Now, when you do start to run out of veins, there have been techniques developing such that it's possible to reopen veins that have been thrombosed or clotted off. These are photos of x-rays from one of our patients where our cardiologist reopened both a vein in the chest and a vein in the groin in a patient who was on the transplant list because of depleted venous access. Because of this, we were able to take the patient off of the transplant list, and she now has 2 or 3 additional access sites available. Another observation we've made that I don't think we know the implications of yet, but in looking at our experience with omega-bin or IV fish oil, we compared 35 patients who had been on soy oil or intralipid versus fish oil, FOL, in this slide. And if you look at the red circle, you can see that all of the catheter-related thromboses, the CRT events that we saw, were in patients that were on soy as opposed to IV fish oil. And this fits in with what we know about the physiology of fish oil, but really hasn't come to application yet in this area. And whether with complex lipid emulsions that have a little fish oil in it, we'll still see this effect, I think is very much an open question. This next question is, how can diarrhea or high ostomy output be controlled? It's elegantly described for you by the previous speaker, so I don't need to talk to you much about that. I'll add a few points, and one is that for the first year or two after intestinal resection, there's more gastric acid secretion than normal. That can cause diarrhea, and so we usually use medications to suppress that. We've already talked about loperamide, cholestyramine. The other point I will add is that fiber may be important in some patients in reducing diarrhea for a number of reasons. We've tried a lot of different products in the past, but we have become fairly convinced that adding some green bean puree to enteral drip feedings or giving it episodically over the course of the day can improve stool consistency and reduce diarrhea. One of the reasons I believe this works is that our patients continue to do it. So this is something if it applies to your situation and you haven't done, something else to consider for diarrhea. The next question is, again, you heard about bowel adaptation from Darlene's presentation. Is there anything I can do to keep my bowel adapting? And this is a question that becomes important both in children and adults. In adults, we think adaptation probably goes on for about 2 years. In children, there's evidence it may go on for 5 years or longer. One of the factors that seems to promote adaptation is hormones secreted by what are called L cells in the lower small bowel or the upper colon. And this hormone is glucagon-like peptide 2, and it stimulates the rest of the bowel to proliferate or to make new cells and to make new villi. And it's become apparent in the last 10 years that this has clinical application. What medications of this type do is stimulate the bowel growth in all the ways that you heard about. They decrease acid secretion and motility, which is usually a good thing, and lead then to a net increase in both fluid and nutrient absorption. The product that's become available since 2012 and much more recently almost available in children is Gatex, and this is a modified GPL2 that has a longer half-life and so is able to function as a medication, whereas the normal hormone is present just for a few minutes. It's indicated for a reduction of dependence on TPN now in both adults and children over a year of age. In the adult studies, significantly more patients experienced a 20% decrease in their daily IV fluid needs and similar numbers for calories, and twice as many patients as the control group got rid of at least a day of TPN while on therapy. And with long-term use, progressively a few more patients come off of TPN over time. We've participated in the pediatric studies, one both of 12 weeks and another longer 24-week study. And these are the data from the 24-week study. This is a control group that continued on its usual care. And these are two groups treated with two different doses of the medication. And you can see again about a 30% decrease in the IV fluid and IV calorie intake of patients while getting the medication with no change in their weight or their weight for height. So the medication decreased their dependence on TPN. And again, a few of these patients came off of TPN. Am I at risk? And if I am, can I prevent kidney stones? Well, who's most at risk? It appears to be patients with short bowel syndrome who have a colon. And there's some complex medical reasons for that relative to calcium and oxalate absorption. But it looks as though about 25% of patients will experience a kidney stone in 5 years. We really don't know much about the prevalence in children, but I can tell you that we do see this problem. The factors that appear to be helpful in preventing kidney stone or kidney stone recurrence are good hydration, diets that are rich in fruits and vegetables to the extent that's possible in your particular situation, a low oxalate diet, and a dietitian can work with you to develop that. Oral calcium supplements help, citrate supplements help, and oral magnesium can also be a good idea, but it's kind of a two-edged medication because it tends to cause diarrhea. A more recent question that's become relevant is, am I getting the right lipid emulsion for me? We're historically used to just dealing with intralipid in the US. Now we have two other options with SMOF and Omegavin. The SMOF is indicated for adults with pediatric applications pending, and the Omegavin is really indicated in pediatric patients who have liver disease. There are differences in the fatty acid composition of these products, intralipid being all soy oil, and from a relative standpoint, lower in the omega-3 fatty acids. The SMOF lipid is a mixed oil blend and a little bit more like what you'd see in a healthy diet. And the Omegavin is a pure fish oil emulsion. So if we look at the oil mixture with SMOF, we find that somewhere around 2 grams per kilo per day supplies fatty acid requirements, maybe a little less in adults, a little more in children. We typically use it in premature infants for patients on long-term TPN with intestinal failure, and it hasn't quite become our standard product yet, but it's used in most of our chronic patients. There's been a Canadian pilot study of patients who were starting to develop evidence of liver disease, and half of the patients were continued on intralipid and half were given the SMOF preparation, SMOF lipid preparation, and the bilirubin decreased in the SMOF group and was more likely to become normal than was true of the intralipid group. So this is not indicated for the prevention of liver disease, or the treatment of liver disease, but may be helpful in preventing its evolution, at least early in the process. Omega-1 is the product that's all fish oil, salmon, and other types of fish, and it was approved last year for pediatric patients who have an elevated direct bilirubin. The standard dose is 1 gram per kilo, and with our clinical experience with Omega-1 is about 85% of patients have their bilirubin values return to normal with ongoing therapy. There have been lots of studies. We've never had a double-blind randomized control study of Omega-1, but there's a lot of experiential evidence and evidence with historical controls that has convinced many of us it has an important role in the management of the development of liver disease in these patients. In patients who have more liver disease that's progressed further, it probably doesn't reduce the liver scarring, but there's still a lot to be learned here. The next question is, am I ready for the big one? And in California, I'm talking about earthquakes, and I guess here we're talking about, Beth, tornadoes? But there's an increasing interest in patients with special medical needs being ready for a natural disaster. We asked the question in our clinic whether it was possible to get people ready for such an event. And these are the data generated by one of our fellows as far as the family's confidence that they could deal with such an event. And you can see at baseline on a scale of 10, patients were at about 4.5, and after our program, they were up at an 8. So it is possible to get ready to some extent for this kind of an event. The Oley newsletter has an article coming out? Out, okay. That has all of this information in terms of the questions we think it's important to ask, things you can do to prepare at home. And for those of you who like being prepared for the expected unexpected, I think this can be a valuable article for you. This was the toolkit we put together. Again, this information is in the Oley newsletter, and I think it's I guess Beth would say an additional burden that we're putting on patients, but it's something that you can work with your physicians and your team in trying to have some degree of readiness. What we have found is while we were able to do this program, it's very hard to maintain this kind of readiness. Your medical records change, products go out of date, and we haven't totally come up with all the answers as to how this can or needs to be done. We've talked some with Oley about whether we should begin to work on this at a national level. And there are lots of places you can go for information. And then the last question is, how can I improve care and access to care for patients with intestinal failure? We do a lot of things at the local level to create a community. We have a supper club where kids with feeding aversions get together to eat. We have family picnics with some of the same intent. We've got family support through a local foundation that's been created by one of our parents. I think from a patient and national standpoint, being involved in Oley is one of the most important things you can do because you get support, but it also gives you an opportunity to become an advocate, and as some of you are, ambassadors for the Oley message. there is the possibility of political action. We can look at past groups such as patients in the AIDS community or the inflammatory bowel disease community who have clearly influenced FDA, Congress, federal policies by becoming involved in what the advocacy group thinks it's needed. And we asked the question about, should federal dollars go to cancer, heart disease, living on Mars, or intestinal failure? And you can help be a part of that, and hopefully we as the medical experts can as well. And the other issue that that's still in front of Congress is assuring coverage for nutritional supplements and essential supplies. And I think, again, this is a mutual effort on the medical community and you as patients. So those are the 10 questions I wanted to go over with you this morning. And if you have any questions, I'll pick those up at the time we do our panel.
Thank you very much. I really enjoyed the talk. Our next topic, navigating the transition to new enteral connectors. Very well-respected clinician in the field, Beth Lyman. And Beth retired. I gave her maybe 2 days before my call to get her out and closer to Oley. So Beth?
Well, good morning, everyone. It's an honor to be here, and I appreciate being asked. I would just like to give a little feedback before I get into my talk about the quality of the talks that I've heard at this meeting, because I have not attended this meeting before, and I was just sitting here thinking, wow. Really, the talk that Dr. Kelly and Dr. Merritt gave were such valuable information for families. I'm thinking these need to be webinars that are out there for families that I worked with up until recently. So that would be my feedback for you. Whatever you sacrificed to come to this meeting, I think that it has been well worth it, because the information you've received is just phenomenal. Okay, so I'm here to talk about the NFIT system, which is about new enteral connectors, and these are my disclosures. Can you see those black slides? I don't know if I did that or not on purpose, but I didn't mean to. I don't know if we need to dim the lights a little bit, but these are, yeah. So hopefully you can see these slides. I'm not sure I can. Okay, so the reason that these connectors came about, the changes, is because it was possible for, and I'll just lay it out there, I am a nurse. It's possible for a nurse to jerry-rig putting enteral products, formulas, medications through an IV. And for those of you that don't think that's ever happened, it has happened. It's happened many times. One of the worst case scenarios was a young woman who was pregnant, 37 weeks pregnant, and a nurse at the end of a third 12-hour shift in a row, a little bit older nurse who was very tired, poor lighting, hooked a prepackaged enteral product into that woman's PICC line. She woke up and knew that something was very, very wrong. And that particular young woman's mother is an RN. She lives about 50 miles from me. I met her at an Aspen meeting and have since had interactions with her since that time. But the main thing that she said at the Aspen meeting was, you all knew about this and you did nothing. And now I don't have my daughter and I don't have my granddaughter. So it is possible to do it. It's also possible for a blood pressure cuff to be hooked in to an IV catheter, and that's happened. And a woman got what's called an air embolus. And then finally, medications can be put down an endotracheal tube. And I tell this story frequently as well, that when I left working in an ICU, I've been a nurse for 42 years, and I worked in an ICU for several years and decided to do a little stint community health. I kept my job for weekends in the ICU. But the nurse they hired to replace me, I kept telling them I didn't think she was competent to do her job. And they kept telling me I was brutal. And I thought, well, you know, maybe so. But the very first weekend that she worked, she put an antacid down a trach tube every 2 hours for that entire shift. So these things can happen, and that's why these connectors exist. This is a picture of the ENFit connector, kind of the generic connector. And what you can see is what I call a stem inside the cap that has the grooves, and we call that area around it a moat. And then the cap that fits over, there's a cap that fits over that to protect it. And then the other end allows the feeding set to be given. So this effort was started by GEDSA, and you can see what that stands for here. They worked with an international organization of standardization. So this is not something that anyone woke up one morning and decided to do in isolation. It's a worldwide effort. The UK, the United Kingdom, has transitioned. They seem to be doing okay with it because I have colleagues over there that I keep in touch with. They're doing well with it. Australia, I have colleagues there. They are making that transition. So this group was formed in 2013, as you can see. So there are changes that involve you as a consumer, and there are changes that involve me as a clinician as well. So I kind of like to highlight some of those without going into a lot of detail. But some of the challenges have been that the syringes required a physician or provider order, and that is a real problem for families. And so unintended consequences of a safety effort resulted in this prescription requirement. And so I will just mention this. Neomed now has a product on the market. It came out in a clinical highlights from Aspen. This thing called NeoConnect at home, different size syringes. You can probably look for other vendors as well, other companies, to come out with similar reusable enteral syringes. What we allow our hospital to do, and for those of you that are consumers, you can advocate for yourself, for your hospital to do the same thing, but we give our families any enteral product, any syringe, any straw, anything that we use to deliver medications to their child. We allow them to take everything comes up from pharmacy with a little barcode and label with the patient's name and medication, right? We scan that so it goes into the medical record, take that label off, put it in a shredder, and then separate the plunger and the barrel, ask the family to clean it, lay it out on a paper towel, and put it in a bin, and they take them home. Another thing that really helps is to use a Sharpie pen to label that syringe, if that's what you're going to use for one dose of your child's medication every day. Label it with that medication and put a Sharpie pen where the dose is, so that over time, when these things wear off, the Sharpie pen doesn't. The way medications are drawn up is important, and that means that you want to make sure that you don't just try to stick the syringe down in the medication. You know, as well as I do, you get a brown bottle from a pharmacy with just about the exact amount of medication, right? So you cannot waste a single drop of medication. So if you stick a straw down in that flat bottle cap, you have to tap it, flush it with air and things like that to make sure you're not wasting any medication. Now, one of the things that you can also do, for those of you that use a pump, there's a white adapter, Christmas tree adapter, that comes on the end of your enteral feeding bag every day. Put that on the end of the ENFit syringe, put that on top of the flat cap if you don't have ENFit caps, and invert it, and that gets rid of the dead space, and that will work for you. So there are tips and ways that you can get through this process. We're all still learning a lot of them, but essentially there are ways to give medications that work, and I did go through that in a workshop a couple days ago. The connectors need to be cleaned because they can acquire residue or dirt or whatever you want to call it in that moat, and it needs to be cleaned. If you don't clean it, the cap will stick and you can't get them apart. Now, if an individual is using a low dose or low profile, excuse me, a low profile gastrostomy, and you have an extension set, what we recommend is that you keep 2 going. We typically order 1 per week for the family, so in 2 weeks you're going to use 2, and every other day you swap and extension sets, and you soak the one that you just took off in water, and then take a toothbrush, a good quality toothbrush, which, by the way, does not mean one that came from a hospital. They're not, I don't think they're very good quality. But a toothbrush that's dedicated for that, or a commercial brush, and clean the connectors really well. Pulse flush the inside of that extension set. Flush it with air to get the water out of it. Leave it open to the air. And then when you hang a new bag, hang a new extension set. And that's kind of the recommendation that we have. Okay, when you go to a facility that is not your local go-to hospital, and in my area, I'm from Kansas City, Missouri, we have a catchment area of families that come 5 or 6 hours away, and so they have a local hospital that they go to for emergency needs, like a fever or something like that, and many of you probably are the same way. You might have a local hospital that you go to. If you are using ENFIT connectors, take adapters with you. If they're using ENFIT supplies and you're not, take adapters with you. So those white caps that come on your enteral feeding sets, you need to have those. Here we have this again, because what I want to show you, or have you think about, is the stuff that can grow on the inside or down in there. We did a study on that, but we didn't culture anything because I met with the FDA twice. I wasn't buying it, that I shouldn't culture this. And so they brought in their microbiologist, and she really sat on me about not culturing the inside of that moat. Just clean it. We are not talking about disinfecting something, because when you wash your dishes, you do the best job you can, and then you use them again. And that was the philosophy that they had. So some of the tips for success to not get debris down in the moat is don't prime the tubing all the way down to the end. Leave a little bit of air that you can see, and then hook it up so that you don't have a puddle form in the moat. If you're using a blended diet, sometimes people have had to add a little bit of water to the formula. And so what I will just say about blended diets, because I know that when we first made this change, we did education tables outside the cafeteria. And so families that were there for clinic appointments and things like that, and were going to grab a bite to eat or a snack, could come and get some education. A lot of those families are on blended diets, and increasingly that trend is happening across the entire United States. And so they were very concerned about the blended diet issue. And so what I will say to you is that all these people know where I live, or I used to live. They know how to get a hold of me, and they're pretty vocal about complaining to me about things. I'm okay with that. I did not get a lot of complaints about blended diets. We simply add 1 ounce of the water that we give at the end of the feed, and they did go through the syringes fine. So we were okay. And then vigorously clean those grooves in order to make it work. And here's a little bit about drawing up the medications. You can see on one side the traditional approach, and everybody gets those flat domes. The manufacturers, the vendors that work with GEDSA, are working on ENFIT types of things like this for us to use. And this is one with the purple top where you set it on the top, and then you invert the syringe that way. The problem is that it's not childproof. You have to leave that dome back in there. Now, when you use the purple cap thing that's on here, people don't know how to get a hold of those. And so that's an issue as well. They don't know how to get a hold of what I would call the bells and whistles of the ENFIT system. They get syringes from their company, not as many as they want many times, but they get syringes from their DME company, but they don't know how to get these other supplies. And so what I will say to you is that is a decision that our hospital made to provide a few of those for the families. We're not going to give anybody a case of those purple top caps, but we are going to give families one or two of the tops that they can use on bottles that they use for medications. We're going to give families some straws. They're going to have to reuse them. But so you can advocate to get those supplies from the place where you get your orders, your provider, your physician. Okay, so these are some other ways that you can draw up the meds. You can put the syringe down in the bottle, particularly if you're talking about an over-the-counter medication where you don't have to worry about wastage of the medication. Anytime that you have a medication that is a critical med, I'm thinking of digoxin, Lasix, narcotics, that you have to have, this is not the way to go. You need to use that white Christmas tree adapter, and because there's no dead space that way and things like that. If otherwise you can handle a little wastage because it's an over-the-counter med, then what you can do is stick the syringe down in the med cup, tap it on your finger to get the most of it out of the moat, swizzle it in a little water so that there's not a lot of stickiness that's going to go down into that moat, and give the medication. We also use medication straws, and that works very effectively as well. This is the cleaning of the connectors. We use hand hygiene, a lot of water, pulse flush down in the moat. If a person has a dangler or a peg tube and they're using that, what I suggest that you do is stick a few of the bristles of the toothbrush down in that stem of the infit connector and just go around vigorously. Use a lot of water, dip it in water, plug it so that debris does not go down into your peg tube. Okay, some of the myths that I've heard is that the blended diets won't go through. That has not been my experience, and I'll just kind of tell you about my experience. 28 years in pediatrics, 10 years in adults, very active in Aspen, get a lot of emails from all around the country because of another project I'm involved with Aspen and NG tubes. So a lot of people know who I am, and they like to complain to me. I've not heard a lot about blended diets. This is another one that the families and I were particularly concerned about, and that is now because we don't have that Christmas tree effect going into the extension set, because most of the time in peds we use low-profile devices, Mickey buttons, AMT mini ones, things like that, that now instead of disconnecting, it'll pull the tube out completely. So I heard that, I was worried about that, I understand that risk. The risk does exist. I don't want to make light of that to anyone in this room. What I'm going to tell you is I haven't seen it happen very often. I just haven't. I haven't seen that the families have had bloody traumatic removals and things like that any more than we had before, and we had them before because some of the kids that I work with are ornery. And they pull at things, and they do things that I don't like them to do. But a parent, a nurse, a caregiver cannot be with a child 24/7. They just can't. Now, what I have heard is that now they're not feeding the bed. Now they don't have to tape the medication port shut every night and things like that. So we have heard some distinct advantages. Is that my timer that I'm done? Oh. Okay, all right. So I haven't seen it in my practice. I'm not saying it doesn't exist, we just haven't seen it. I've heard that medication doses are not going to be accurate now that we have the ENFit connectors. We have an extremely active cardiovascular surgery department, and they use critical dose meds. We have not seen drug levels be unusual. We haven't seen seizure therapeutic drug levels be abnormal, anything like that. The low-dose syringe has a stem in the center to negate the dead space issue. I've heard that the system is unsafe. So I'm not exactly sure where that's coming from, but I've heard that and gotten some emails about that. But from my vantage point, 42 years in nursing, I can tell you for a fact I would never put a patient in harm's way, never have, and I haven't seen it to be unsafe. I know there are concerns about that. I don't want to negate the value of those concerns. I'm just telling you I haven't seen it as a safety issue. And I will say that this nurse, Glenda Rogers, who lost her daughter and her granddaughter in one foul swoop, probably would think that it might be worth the risk. Now, I will also tell you that 7 years to the day after that event happened, a nurse I shared an office with told me about that because she was on that unit. And she had to sign a paper that she would not talk to anyone about it for 7 years. So 7 years and 1 day later, she told me about it with a bucket load of tears. She had been in therapy for a long time. So when a situation like this happens, do not just think the family is impacted by it. Anyone who's involved at all, especially on a labor and delivery unit where the thing you're supposed to take home is a healthy baby swaddled in a cute little color-appropriate blanket, they were devastated by that. So, the facts. Some of these supplies are a challenge. I can just tell you that, and I get that. So, what we did, we had challenges. And what we did was we decided that our DME companies, we would go with a softer rollout with them. In other words, we converted almost 2 years at this time in the second Tuesday of July 2017. And our DME companies, they knew about it. We had communicated with them. We tried everything we could. They had non-infant, they had legacy supplies that they needed to use up before they could go to the infant supplies because it's a cost issue for them. And our DME companies provide a tremendous service for our families. And we did not want them to take a hit financially. And so we said, okay, we'll go with just dispense what you've got, but by fall, if we're still dealing with legacy supplies, we may have to talk. And so over time, some of the smaller companies were able to spin down their supplies that they had and go ahead and start dispensing legacy supplies. We kept on good footing with them and with our families, and we let them know. So we never had a way to clean legacy supplies that was a standard before. Now we do. We did that research, our hospital did. And our families see this as a safety issue that protects their children. They don't want to feed the bed anymore. So we still have families coming in that are admitted that are on legacy supplies because they don't come to the hospital very often. Some of these kids are pretty healthy. And so when they come, the families are like, yeah, we want that stuff. We want that thing that screws in so we don't have to feed the bed. So this is just a quote that I think is worth thinking about. And for those of you that are consumers in the room, that are families, caregivers, people that do tube feedings, what you need to know is that in the healthcare world, we do care about safety because we don't want anyone injured. And if you don't know the safe way to do things, somebody is going to get injured. And we have plenty of data to show that. Thank you very much.
I want to thank all of our speakers for being here today. Those were all fascinating conversations. To me, personally, I learned quite a bit today from all the different ones. And what we're going to do now is we're going to open it up to question and answers. And unlike the first couple of days where we had the stands there, Joan and I are actually going to run around to you. We're tired, but we know you're tired too. So we're going to run around and as you have questions, we'll do that. The first one I'm going to open up, though, while I'm here because I have the microphone. So I'm going to ask my first question is, Dr. Merritt, you actually talked about some centers of care, you know, having that kind of a concept. So if we were looking for those, first of all, like, where are they? I need the inside scoop. But also, how would we identify those centers of care?
I'm going to defer this a little bit.
Yeah, you just have to do a direct on.
Okay. Yeah, I'm going to defer a little bit to Joan because at least in the past, Oley has had a list of such programs. Do you still have that?
You know, we did. We had a section on our website that was centers of excellence. And then we toned that down to centers with experience. And then we kind of decided that we don't know if they have experience or at what level their experience was. So we pulled it down, and it will be coming back on the website as Find a Clinician. We're working on the questionnaires that we'll put in front of people who want to be listed. And it should be framed in a sense where whoever goes to that area of the website will be able to tell, is it a full intestinal rehab program with all the different disciplines, or all the way down to it may be one physician who feels they have the experience and with one or two patients. That will give whoever's looking for someone in that area a sense of what their needs are and where they can go. Does that make sense?
It will be helpful. These tend to be not universally, but they tend to be at academic or university centers or large, in the pediatric situation, children's hospitals. But I think Oley can help you navigate that until the new website information is up.
So I just wanted to add something about the program that Joan's mentioning. It'll be a resource, but it'll be self-reported. So it'll be clinicians telling us that they have experience in a certain field, and we're trying to develop parameters so that you have an idea of how much experience they have as you use it, but there's no standard for a center of excellence in GI care or intestinal failure, so we're not opening that bag.
That's right. That's right. We're pulling back a little.
Dr. Merritt, you mentioned that the GLP-2 hormone could be effective in even perhaps weaning people off of TPN. I think you correlated that with short bowel syndrome alone. Maybe I'm wrong about that, but that's what I'm asking. Might it also be helpful for patients suffering from motility disorders?
I think it's a question a lot of us have, and we have very little information. It has been used in patients with malabsorption, which may or may not have been short gut related with Crohn's disease. And there was a series of patients who came off of TPN simultaneously with the use of Gateks who had malabsorptive disorders. So there is information beyond pure short gut, but from what we know about motility disorders, I don't think at the moment we have a reason to believe this is going to change the situation.
She's got one over there.
I have two quick questions for Dr. Merritt, if you don't mind. The first one is with regards to fish oil to prevent thrombosis, I believe you mentioned. Now, when you are saying to give fish oil via IV, is that only if you are not already on SMOF or Omegaven, or would you still give additional fish oil even if you are on SMOF or Omegaven?
We haven't got that far.
Okay.
What we published was an observation. I had this notion that we hadn't seen any thromboses in the 50 or so patients that we had treated with Omegaven. And so one of my colleagues pulled the information on that, and it turned out to be true. All of our thromboses had been in patients getting the soy oil. We know that fish oil can alter platelet function in ways that reduce the tendency towards other kinds of thromboses. And so conceptually it makes sense. This hasn't been reduced to practice in terms of a recommendation that people should be on a certain amount of fish oil. Our observation hasn't been confirmed, to my knowledge, yet by other people. So it's simply something to make you aware of that may have potential for the future, but it's not embodied in a clinical recommendation.
Okay. I have one more question, and this is with regards to Gateks. And my son Zeke, he has total intestinal aganglionosis, and he has been resectioned and has a jejunostomy. And we were barely making progress on enteral feeds, and then his gallbladder got unhappy with us, and we had to have it removed. So we are now starting over with feeds, and my question is, would it be appropriate to start Gateks if if our GI determines that he's a good fit with Gadex, would it be appropriate to start that right away with feeds, or should feeds reach a certain point to then start Gadex?
I don't think we really have the information on your question, because the pediatric studies that have been done have been on patients who were stable on a TPN and an enteral or an oral feeding regimen at the time the studies were initiated. So, for example, we don't know if Gatex may be less or more effective if it started, for example, right after the initial surgery that leads to the short gut. So these are unanswered questions. We know that in stable pediatric patients, dependent on TPN, there's a high likelihood that their TPN dependency will be reduced.
Definitely an understudied population, for sure.
Over here.
Yes, Ms. Lyman, most people that like the infant, so they say they stop feeding the bed, seem to be unaware the AMT for many years has been selling a simple-to-use clamp that sells for $15 that solves that problem. So that's not a problem that infant should be out attempting to solve by turning the lives of every tubie in the world upside down for such a simple problem. And my question following that is, when is DEDSA and the people like yourself who are pushing the infant project, when are y'all going to quit telling the lie about Robin and her child dying as a result of not having infant? All the infants and extras in the world would not have changed that situation. So she did not die of a feeding tube enteral miscarriage. She died because someone erroneously put an IV spike into an enteral feedback. That problem was solved almost immediately the next year by redesigning the spike. So you cannot spike an IV spike into an enteral bag. But yet, again, that lie is told at every conference by people, one after another, pushing infant. I have been a tube feeder almost 6 years. I use a 24 French standard. And I highly resent the fact that my ability to feed myself is being stripped away by people like Nestle and Abbott, who are seeking to enrich their corporations, because for the first time in history, around 2010, when Facebook and other social media became popular, tubies that had been relegated to the back room and forgotten about were able to communicate. A tubie mother in New York of an infant who was having a feeding tube problem that switched to blenderized food should now communicate with a tubie mother in California. And so the use of blenderized foods spread rapidly. As this happened, the producers of the high fructose corn syrup formula sold by Abbott and Nestle, I'm a retired marketing guy. I know how marketing works. And they became desperate to increase their sales rather than suffer the decrease in sales that blenderized tube feeding has brought about. So Infit is their solution. Infit was their design to prohibit the use of blenderized foods. I gravity feed, as many people gravity feed the blenderized diet. I do not choose to inject my gut with a syringe and plunger like I'm trying to inject the family's holiday turkey. And I really highly resent the continual lying about Robin and her unborn child. Thank you.
Okay, so I guess that I didn't catch all of that, so I'll start with the AMT clamp. I am very well aware of it. It does not close the med port, and the med port pops open on a lot of these things as well. As far as blended diets go, and this issue about blended diets, it's a growing trend in the United States to use blended diets. Children and adults are doing well on it. And from my experience, which isn't really very slight, we used a lot of blended diets, and the children did okay. So, and then finally to your statement about the issue of IV tubing and things like that, up until InFit, it was possible, and I can tell you this, to jerry-rig an enteral stopcock and put it on an IV catheter. And so it did stop a lot of things. So in the technical world of a nurse going into an ICU and seeing a shelf with hundreds of products on it, if these stopcocks are close by each other, the possibility exists. So I think we can agree to respectfully disagree. I respect your position. I definitely do.
Thank you. We have another question.
I have one related to this that I think might help people from both sides of the camp. I agree with his statement. I have myself personally let many families know about the AMT mini clamp. It was passed on to me by another mother. I know everyone in this room wished their DMEs and those people you get on your refill line knew all about their products, but guys, listen, they don't. Our Enteral families, and I did TPN for a while with my daughter. I couldn't wrap my brain around all the possibilities. It was very complex, but for Enteral, there's so many products and the staff are not trained. And I had a long talk with Quorum, so we won't go there. But the thing you should know is there is a clamp if you're on Legacy. It is a great clamp. It worked miracles for my daughter who was on an NG, who's some of the fits actually push the extension sets out for whatever reason, so that works. The second thing that nobody ever seems to know that I'm constantly telling everyone about, because it works for both Mickey and Minnie, is that AMT makes a specific glow-in-the-dark extension that has a stick in the med port. There is zero chance you will ever feed the bed. We've not used a roll of tape in 4 years to close our med port. If your choice is so we recently had a hospital stay. I had no problem with switching his extension to InFit. I think the hospital-based needs for InFit are valid. It's a great program. I highly disagree with the use of InFit in the home. I think I do disagree that I think you're going to see over time. When I say a traumatic tube removal, I don't mean there's bleeding. I mean the balloon comes out of the stoma intact. That's traumatic because what happens is the stoma swells, and this has happened to my son. The stoma swells, and then you can lose your tract. So we went in with a traumatic tube removal where the balloon came out, and it was super painful, a tremendous amount of dilation, and he almost lost his tract. I would like to propose that InFit consider a quick release mechanism so that if there's a certain amount of pressure, that it will come off. That's not going to happen lying in bed. You're not going to feed your bed. So someone approached me and asked me if I'd be open to that idea as a consumer, and I said, yes, I would. I think that's a great idea. Because again, you still solve the problem of feeding the bed, which we've done. But if you would like to continue using Legacy, that is the only extension that I have ever used that does not leak. And I know that AMT has said they're committed to continuing providing Legacy options. So if you're willing to switch your button, the AMT Mini is a good product. That is an option for you. So either if you want more time to get into the InFit world, you have that. So there's some things that you can do to sort of ease up your experience.
Thank you for sharing.
I just want to say one thing. I'm Frank Untitled. I'm chairman of the board of GEDSA, recently been voted in. We are working on providing some ways where patients can interact with the members of GEDSA via some webcasts, so we can start fielding ideas on ways we can do and provide better products and differentiated products at GEDSA members' choice, right? So not sure where that's gonna go, not sure what products we can go, but we certainly wanna give a voice to the customer or to the patients. We always wanna put our patients first. We're doing a better job, I think, as an organization in doing that, and we're taking the right steps to do that for you guys. So be patient with us, but these are becoming via the Oley Foundation with GEDSA. So we would love to have as many patients on there, help us provide some ideas for just like what happens there. That's something that we discussed already. Some company probably will take the lead on that, right? But it's going to take a little time. It's going to take some more teamwork from you guys. Okay. Yeah.
This could be an afterthought.
Yeah, I agree.
You can't take too much time. You gotta get us in there.
Yeah. So yeah, but remember, you have to remember too, though, from idea to conception to product, it's going to take a little bit of time. Yeah.
So I'm just saying, the quicker you can get consumer in
Yeah.
the better.
Absolutely. So I can't speak for any company. I can speak for our company that I work for. My full-time job is that we always put the customer first, and we're looking at customer insights first before we design anything else. So I know where we're going to be at. I know where we're going. I'm confident about the products that we have coming down the line. But I want to also bring more GEDSA members in, and especially bring you guys in. Okay?
That sounds very good. I just want to remind the audience, so we can be thinking, that we also want to have any lingering questions that you've had over the last 2 days. It was 20-minute talk, 20-minute talk, 20-minute talk, 15 minutes for discussion and questions. If you have any, start thinking about those questions, and we'll tackle them here. We'll try to anyway.
Hi, my question is for Dr. Merritt in regards to GADX or GADX, and if there's a certain segment of the intestine that is more responsive to that, going back to our son who has a jejunostomy, we think maybe he has 50 centimeters, it just past the ligament of Treitz was where we were told the transition zone is. So that's all we have to work with, and when we're exploring GADX, is there any study or anything that has shown that that segment of the intestine is more or less responsive than another section?
I think the adult studies have been very positive for that population, but it's been very difficult to tease out the question I think we're all tempted to ask is who benefits most? And there are a lot of ways of looking at that. One is, reducing fluid needs, for example, in somebody with a jejunostomy. It's another situation if you have somebody who is, say, only 20% dependent on TPN, and you could possibly get that patient off of TPN. Is that the patient who's going to benefit most? The pediatric studies are still pretty limited in terms of numbers. There's more data coming out. But I think you need, at the individual level, you need to discuss this with your care team and decide from a risk-benefit likelihood of getting a measurable improvement either in your quality of life or medical situation. Is this right for you? And then there's also the aspect of getting the insurance payer to agree with that decision. And we don't know a lot about how that's going to play out yet in the pediatric situation.
Thank you.
Hi, my daughter is on TPN, and they want to, for 2 years now, and they want to switch to the phospholipids, but she's not showing any sign of liver issue, and I'm just wondering, does it make sense to switch if everything's going fine? And in addition, if she has fish sensitivities, if she were to take it by mouth, do we have to worry about the fish oil?
That's a question we often face. I have chronic patients who remain on soy oil, IV soy oil, and they don't at least have apparent evidence of liver disease. Sometimes you have to look a little deeper to get the final answer on whether that's present. And I think if you go by current label indications, we're probably not there yet in terms of pediatrics. Because the approval is for adults, and a lot of us are using it in children.
She's 20.
20, yeah, well, and so you can go either way, but one of the ways an aspect of the question you could look at would be things like vitamin E levels, essential fatty acid levels, whether those are where you want them on the particular lipid product that you happen to be on. In some ways, it's easier to get what historically we have considered normal essential fatty acid patterns with intralipid than with some of these other products, particularly if they're being used in low dose. But it's a very complex issue, and I don't think there is a standardized answer for your question. I think it's like so many things in this field, you need to work it out with your team and decide what's best for you.
I actually have a question for Darlene to get you involved. You were talking about the importance of the ileum. And so if you've got say a child who is not resected, they have just motility disorders, how would you know, what would be the symptoms that like the ileum is angry with us or involved? Is there any way to know that?
Dawn? Okay. You thought I was asleep, didn't you?
No, I feel you're left out, and I just wanted to make sure
okay.
you're.
And to feel like the ileum is being left out of what? What is this, your...
So you were talking about the importance of the ileum.
Yeah.
And you were
I was specifically talking about absorption
right.
of fat and
so how would you know in a patient who is not resected, for example, are there like symptoms that are going to happen, or is it the same thing whether they have their gut or they have been resected or it's just a motility disorder? How would you know the ileum's angry at you?
So you're proposing that nothing reaches the ileum? Is that if
say like, for example, pain in that area, in that general vicinity?
No, I don't think there'd be pain. Okay. Well, there might be pain if things aren't moving through, but it isn't really related. Any section where the material is not moving through could cause pain. And pain is, I don't think there's any specific pain that would explain that. But the main things, vitamin B12, I mean, one thing you can do is check the vitamin B12 level and see it, but that may not be just because things are not moving down. It may be any of many causes.
Right.
And as far as the fat, greasy stools would be probably the one thing, or more foul-smelling stools.
Awesome. She has a follow-up to that.
So I was just about to ask, what does it mean if your child has his bowel and has extremely foul, greasy stools? Because that's my son. And he's had a history of C. diff. This smell can be so offensive that we thought he had C. diff, which he didn't. We were thankful for that. It's green. It looks like liquid avocado, and it goes between it's never hard, semi-formed. I mean, like if you touch it, it's not formed, too explosive. And we can get no help. We don't know what to do, and it's very uncomfortable, and it's urgent. Meaning he has the urgency where it's like he's running to the bathroom and doesn't always have the ability to control it. Does you relate to this?
Well,
okay.
What you're describing, I think, could be bacterial overgrowth.
Okay, which is related to the motility issue you had described.
Yes.
Yeah.
Often it is.
Including the greasy?
And sometimes, occasionally, what will happen is that they may have at one point done an anastomosis between, a stitching together between the colon and the small bowel.
No, he's intact. This is just like no.
But I'm just saying that that's another reason that this can happen is if they've anastomosed or connected the small bowel, the colon to the small bowel, and there's not a valve in there anymore, then you can also get this kind of bacterial overgrowth. It usually happens pretty soon after the surgery, but yeah, that's another way. Or sometimes there are inadvertent loops that occur because of a surgical intervention. Sorry, I hope everybody was hearing me.
So for those who
But-
aren't surgically altered, what would explain that then? Just motility and bacterial?
Well, motility certainly can cause bacterial overgrowth.
Including the greasy stool?
Yes.
Because you had mentioned that castor oil-like effect?
Mm-hmm.
And that came from what part of the body again?
Well, often it's the colon, but if there's bacterial overgrowth, it can come from anywhere in
Okay.
the small bowel. And I'm glad you made me straighten that out. Yeah, it's not just colon. In motility disorders, bacteria can be high anywhere.
Thank you very much.
Mhm.
You can give
This is for Ms. Lyman. My name is David. I've been tube feeding for 7 years. And just when I'm comfortable with the way I tube feed, along comes Infit to wreck my life and create detrimental issues with the way I feed. You know, tube feeders feed in a variety of different ways, so one size doesn't fit all. And there's two sides to every story, and there's only one set of facts. And we presented the facts to Getza and many other people, including you. I've written you. You never answered me, but I wrote you several times. But we continue to just try to go on and live life in the way we live now, but now it's going to be changed in detrimental ways. It's just one set of facts. And the facts we presented are Infit still misconnects with adult tracheotomy tubes. You can take a form that could fit perfectly into a trach tube, and it's form that could be put into a patient's airway, creating a terrible situation. Infit doesn't comply with the California law in that respect because it misfits with adult trach tubes. It misfits balloon ports. IVs fit into balloon ports. It just doesn't solve a contemporary misconnection problem. I mean, I could go on and on, list the facts. I think you know what they are because I've sent you emails on that. But I hear a lot of stories where the dog got tangled in a line and pulled the tube right out of the body on an Infit syringe because that's the weakest point. And that resulted in a trip to the emergency room. But that's all I got to say. I just want to tell you that not happy with that, and we need an alternative to correct those issues.
My understanding is that there are 5 or 6 connectors that are being redesigned. Enfit was the first, but the other connections that you talk about eventually should be resolved by changing those connections to things that don't fit with Enfit or anything else. So it's not all going to happen at once. They've done it step by step, and I think they're working on 1 or 2 others now.
Neuroaxis is next. I can't speak much for it, but as far as misconnections, when the UK moved, there are over 300 million Enfit devices that have been sold in Europe without any complaint on a misconnection. So you can look in the database. That's the data that we have. We understand there's different ways that you can do it. You can take a PEG tube if you wanted to, and you can just not put a Y port on it and use a 24 French PEG tube and feed it the way you want. It's your choice. So there are ways, right, where you can address that as a blenderized tube feeder. As far as the acute care space, we understand that there's a risk there, and we want to reduce it, and that's really where we stand. As far as the papers and studies that have been conducted. The Mayo Clinic, we had a great speaker yesterday, Dr. Raman Priyamundi, walked you guys through about blenderized tube feedings and using different blenders at different time periods with different consistencies and viscosities and found no discernible difference between the flow rates of them. Specifically with the Ninja, I guess, or the Nutrex Ninja, I think that was the one. Yeah, 14 French, which was an aberrant event on that actually tube has been removed and no longer sold. So there's data that we've built, and we'll continue to, they'll continue to have studies. Science never has final questions, or there are final answers to questions. There's always more questions to be answered. But yeah, so we wanted to make sure we understood some data that was out there as well.
Just a quick follow-up, and I think to echo what David was saying and to reiterate the point, as a concern perhaps for tube feeders, that the ENFit syringe and the ENFit formula pump set does fit securely into an adult tracheostomy tube. So for those who do choose to use an ENFit pump set or an ENFit syringe, just be aware that it does misconnect with a tracheostomy airway. And I think the other point that he was making, which is very valid too, is that the balloon inflation ports on all balloon G-tubes, whether they be low profile balloon G-tubes or the dangler balloon G-tubes, they all do have an inflation port, and that is an IV lure inflation port, and that has always been a source of misconnection, which still exists today with or without ENFit. And I think the point was validly made as well that the Robin Rogers death, as tragic as it was along with her unborn baby, it was caused because a IV line was erroneously spiked into an enteral formula bag. It was the spike set into the enteral bag, and that spike set is not addressed by ENFit. That problem was corrected in short order after the tragic death. So ENFit does nothing to do with that spike set. ENFit addresses other things. ENFit does not address the IV ports on balloon tubes, and ENFit does gravely misconnect with adult tracheostomy tubes.
Thank you. I'd like to just explain Oley's position, well, lack of position, but the issues that face both parenteral and enteral consumers. And I'd like to tell, and I'm going to stand right in front, we have heard you. Honestly, we have organized a summit in Atlanta. We have brought manufacturers together with the Mayo folks, with the FDA. And at one point, no one was talking to each other. So you're correct in saying the patient input was not involved in the beginning, but we are now. And honestly, there are so many things that have been addressed and will be addressed. It just takes time, so I plead with you for your patience. Honestly, we will get there, or we'll get as close as we possibly can to where you want to be. Our position is, we do not want to support an initiative that benefits one part of our population, our membership, and harms another. Seriously, you could bring me to tears, but it's where we are.
I can speak as the president of the board. Last night, we had a conversation at a board meeting. This came up, of course. This is at the heart. And we have a very firm position on patient safety. Right now, we do not know, as the board, we do not know as Oley, we do not know where some of this stuff's going to land. We're in the process of these things. But I can assure you that we want that conversation to continue. We want those discussions to be had. We want the members to be heard. We also have a very strong position on patient safety. What does that look like? We're still working on that, but that's along with Joan, I want to just echo that sentiment, is we want patients safe. What does that look like? Let's figure it out.
And honestly, when we get a call from one of our ambassadors who has both a tube and a catheter, does that mean, no, that's you? Good. And she says to me, Joan, fight for this misconnection. It doesn't mean harm you, because we don't want to do that or inconvenience the way you feed yourself. Honestly, we want to get there. But when she says to me, and this is a nurse, she says to me, Joan, I have to admit I was over-medicated, but I had my syringes laid out, and she said, I put the wrong medication into my central line. She jammed it in. She was taking some medication, a little over-medicated. She said, honestly, a quick trip to the ER resolved my issue. But when you hear things, another woman with 3 kids on IV, she said, the attempts to misconnect scare me to death. She said, just scare me to death. And they do happen, and they're not reportable incidents. So they're out there, and we're aware of both. So if it seems like we're on the fence, it's because we are. And that's fair. Okay, and
Yeah, some of us are going to be having taxis waiting out in front to take us to O'Hare.
oh,
So,
where are you going?
I'm going home.
Okay. Okay.
So I'm wondering
Okay.
if we can just go ahead and start.
Oh, okay, that would be good. So can we end there? Is that fair? Let's end. Okay, we'll have Dr. Kelly holding one of our candles, and I'd like to invite Sue Caprecki forward to hold another one. There we go. Oh, Queen Dr. Kelly, there she goes. Okay, and Dr. Kelly. And there are, this takes us from a lively session into another session where we remember those who have passed during the year, since the last conference at least. And Dr. Lynn Howard speaking some words that need to be spoken this morning.
So I'm going to briefly tell you about a elderly matriarch of a large Syracuse family who died this past year. Her name was Kay Oldenburg. Kay was the widow of Clarence Oldenburg, and Clarence had the nickname Oley. So you begin to see the connection. Clarence had had Crohn's for many years, short bowel syndrome, and had spent over 6 years pretty much continuously in the Syracuse VA, and this was back in the 70s. And he went home briefly, but was back in quickly with malnutrition and dehydration. He apparently, or his physicians apparently, heard about the program that we had started in Albany, and he was transferred to Albany, and he was our 5th patient that we trained and sent home on parental nutrition. This was back in about 77. With Kay's help, Clarence did extremely well, and he had a younger brother, Bill, who proposed a foundation to make this liberating therapy more nationally available. Bill was a very flamboyant mortgage broker in San Francisco, and he came up and said, look, I'll offer you $1 million if you'll develop a foundation that will be available to everybody else of this kind. So with my chief of medicine, John Ballant, his daughter Jane Ballant, many of you may know, we accepted this offer, and we eventually traveled to San Francisco, and there with Oley, Kay and Bill. We had a very festive lunch, and we had an initial check for $200,000. We moved with Aspen to take responsibility for evaluating home parental and enteral outcome with a registry. We accepted responsibility from the Kunin family to continue and to some extent upgrade the Lifeline letter. Eventually, it became clear that Bill Oldenburg had his own financial troubles, and there was no further financial help forthcoming. However, despite this, we were already ensconced in a lot of obligation, and we had the help of some very generous industry and some families who gave what they could. And so the Oley Foundation began to grow. Oley and Kay continued to drive several times a year to Albany to participate in meetings, and they then eventually Clarence died, passed on, and Kay came to Albany with many members of her family, even so. And she was, in fact, a very stalwart, stabilizing, gracious lady, quite important to the Oley Foundation. Thank you. Now we're going to have the ceremony to recognize the many friends that we've lost this past year. And I'm going to briefly read a poem as you start to show these photographs. Do not stand at my grave and weep. I'm not there. I do not sleep. I'm 1,000 winds that blow. I'm the diamond glints on snow. I'm the sunlight on ripened grain. I'm the gentle autumn rain. When you awaken in the morning hush, I'm the swift uplifting rush of quiet birds in circle flight. I'm the soft stars that shine at night. Do not stand at my grave and cry, I'm not there.
for once, I'm not going to be funny up here, but I'm going to reflect that with each and every loss that we learn about, we grieve, we cry. This is family. We are family, sometimes closer than others, but family in a sense that someone included my brother in the slideshow. And I mean, it doesn't hurt any more or any less than any one of the people that were showcased today. And I noticed our list today is a little bit shorter than it was last year. That's a good thing. So carry on, and let's go walk. Put your candle out, Hannah. And let's go walk wherever it happened to be, and be thankful we're getting together in the Grove Pavilion for the picnic.